Bismillahirrahmanirrahim. So I'll be presenting basic anatomy of the spine. That is one of the series for postgraduate teaching program. Uh, so, so the brief outline of my presentation, we will be discussing the basic embryology, the brief outline only, the development of different vertebral curves, which include primary and secondary curves. The basic regions of vertebral column starting from cervical, thoracic, lumbar, and sacral regions, the difference between typical and atypical vertebra, and then the detailed regional anatomy of upper cervical spine, lower cervical spine, thoracic, lumbar, and sacrococcygeal regions. In the end, we'll be touching also all the ligaments and joints that are in the vertebral column. And the last, we'll discuss arterial and venous supply of the spine. If you look at the basic embryology of the spine, this all happens during the 4th week of development, and notochord and somites are the most important structures. Uh, as we know, during the 4th week, there is development of mesoderm along with ectoderm and endoderm, and the mesoderm is divided into intermediate, lateral, and paraxial types. It's the paraxial type which is responsible for development of vertebral column and skeletal muscles. If you look at other mesoderms, they are intermediate and lateral variety, and they are responsible for urogenital, pulmonary, and cardiac systems. So if there is defect in the paraxial mesoderm, there are chances that there will be defect in the other urogenital, pulmonary, and cardiac systems. So that is the basis of investigating all these systems while investigating any of the congenital deformities like scoliosis and kyphosis. If you look at the basic development of the spine, initially there are 3 ossification centers. They are called primary ossification centers. Out of them, the one is in the centrum, that is body, and 2 are in vertebral arches. Okay, and ultimately at the age of around 3 to 6 years, there is fusion of the centrum with the vertebral arches, and there is development of 5 ossification centers at the puberty. So one is in the upper end plate or superior body, one is inferior body, 2 at the tip of transverse processes on each side, and the one is at the tip of a spinous process. If you look at the curves, different curves, so in utero and when the baby is born, there is a single curve that is called primary curve, which is kyphotic. So initially there is thoracic and sacral curves, and they are kyphotic. And when the baby starts holding the neck, so there is development of cervical curve, that is the lordotic curve. So that is a secondary curve basically. And when the baby starts standing and walking, there is development of lumbar curve. The main basis of that bend rod is that it increases the tenfold ability of spine to bear the loads. These are again different curves, cervical curve, thoracic curve, lumbar, and sacral curves. If you see from proximal to distal, there is increase in the vertebral body height, and there is very regional variation of the vertebral bodies to accommodate the functional demands of that region. If you look at the surgical curves, sagittal plane curves, so the cervical lordosis is around 20 to 40 degrees, thoracic kyphosis is around 20 to 40 degrees, and lumbar lordosis is again around 30 to 50 degrees. The terminology, another terminology which is used in spine is functional spinal unit, which is basically composed of 2 adjacent vertebrae along with disc and the facet joints. This unit is responsible for the movement of the joint. Coming towards the typical vertebra are those vertebrae in which there is body anteriorly, and posteriorly there is vertebral arch, which is composed of pedicles and lamina, and there are 7 processes. There is spinous process, 2 transverse processes, and 4 articular processes, superior and inferior articular facets on both the sides. If you look at the lamina, it's the origination point for rest of the posterior elements. It basically transmits the forces from posterior elements to the pedicles, which is a thick and robust structure. If you look at the spinous process and transverse processes, they are basically the sites for muscle attachment, and they serve to increase the lever arm for muscles of the vertebral column. If you look at the atypical vertebra, they are basically at the transition point. So when the cervical spine is starting or when the cervical spine is ending, and when the thoracic spine is starting, so there is variation at the transition point. So transition vertebra will have features of both the sides, cervical and thoracic, and the end of the thoracic level will have features of some lumbar vertebra. So cervical vertebra C1, C2, C7, and thoracic vertebra T1, T9, and T10 and T12, they have got features of the lower thoracic have features of lumbar vertebra, while upper thoracic have features of cervical spine. If you look at the detailed anatomy of cervical spine, there are 7 cervical vertebrae which are identified as C1 to C7. They form the neck region of the spine. The first 2 vertebrae, they are atlas and axis, they are different because they perform functions that are not shared by the other cervical vertebra. And the primary function of cervical spine is mobility, support, and protection of spinal cord and nerve roots. So there are 6 intervertebral discs, and along with that, there are 8 pairs of exiting nerves. Okay. The most of the lordosis, if you can see on the this 3D image, the most of lordosis is at level of C1 and C2 segments. Okay, and that is the most mobile area. Coming towards the detailed anatomy of atlas, this is the first cervical vertebra which is ring-shaped. There is no body, and it is formed by 2 lateral masses. Okay, it contains 2 kidney-shaped facets superiorly. These to articulate with the occipital condyles, that is atlanto-occipital joint. This joint basically allows flexion and extension of the neck. That is the yes movement. Okay, so that is the main movement at that joint. The transverse processes of the atlas, they project laterally. Okay, and they have got foramen transverse cerium, which harbors the vertebral artery. If we look at the anterior arch of the C1, it articulates with the dens of the C2, and this is supported by the transverse ligament. And it is mentioned that the transverse ligament is stronger than the dens. So the dens fractures before transverse ligament, so it's a great stability for the C1, C2 articulation. If you look at the C1 vertebra, there is a notch. There is just posterior to the occipital condyles here, and which is a site for vertebral artery. So from here, the vertebral artery turns and goes into the brain side. And this is the common site of fracture of atlas. Coming to the axis, the typical or most distinctive feature of this vertebra is the strong odontite process that is called dens, which rises perpendicularly from the upper surface of body. It provides attachment to different ligaments at the apex. It provides attachment to the apical ligament, and on each side there are alar ligaments. Okay, and encircling the dens along with the C1, it is the transverse ligament. And as we mentioned, the transverse ligament is stronger than the dens. Apical ligaments basically limit rotation of upper cervical spine, and alar ligaments, they limit rotation of, again, upper cervical spine. If you look at the anterior surface of the body of C2, it provides attachment to ALL, and the posterior surface provides attachment to the PLL. The joint between C1 and C2, that is atlantoaxial joint. It's the most mobile joint in the spine. There are basically 3 joints. One is pivot joint, and two these are the lateral gliding plane. They've got movement in lateral gliding plane. In this, the rotation is the primary movement. So the no movement happens at atlantoaxial joint, and 60% of cervical rotation comes from atlantoaxial articulation. If you look at the cervical vertebra from C3 to C6, they are among the smallest vertebra, and they are the lightest, and their spinous processes are short and bifid. That is the characteristic point of these vertebra. They have got, again, transverse processes of the which contain foramen through which the vertebral artery pass on their ways to the brain above. If you look at the pedicles, they are directed laterally and backward. Okay, there. And the lamina, they are basically narrow and thinner above than below, and the vertebral foramen is large and triangular in shape. The specific points about C6 vertebra is that it contains palpable carotid tubercle, which is a valuable landmark for anterior approaches of cervical spine. And at the transition point, that is C7, it has got non-bifid spinous process. Another characteristic point of cervical vertebra is that there are presence of lateral masses, which consists of lateral superior and inferior facets, and they have got inclination of about 40 to 45 degrees. The facet joints in the cervical spine, they resist anterior translation and rotation of the spine. And the vertebral artery traverses through all the foramens except C7. If you look at the C7 vertebra, it is the longest spinous process, which is palpable. If you feel it clinically, this is not bifid, okay, and it is the transition vertebra, so it has got features of thoracic vertebra. If you look at these movements in the cervical spine, approximately 50% of flexion extension movements occur at the atlanto-occipital joint, that is between the occipital condyles and C1. And the 50% of rotation occurs in atlanto-axial joint, that is C1 and C2. So that is no movement, and the proximally at occipito atlanto-occipital joint is the yes movement. Okay, so there are lesser amounts of flexion and extension, rotation, and lateral bending occur segmentally between C2 to C7. So distally there is less movement, and proximally there is more movement. If you look at the thoracic vertebra, there are 12 thoracic vertebrae which are almost typical, but at the transition points again, they have got features of some of the cervical spine, and at the end they have got features of lumbar spine. They are larger than the cervical vertebra. Okay, if we look at the anterior, posterior, and transverse diameter of the thoracic vertebra, they are larger than cervical spine. Body is somewhat heart-shaped, and the characteristic point of these thoracic vertebrae is that they have got demi-facets at the sides for the articulation of the ribs. Okay, the spinous process is long and hooks sharply downward, and it basically overlaps. Okay, so there is no space between the bony lamina and the spinous process at thoracic spine. If you look at the facet joint orientation, they are in coronal plane. Okay, so the chances of jump facet are very less in the case of thoracic spine because of orientation of the facets. If you look at the thoracic pedicle anatomy, the pedicle is a strong bridge between anterior and posterior columns. So basically, it transmits the bending forces from posterior elements to the anterior elements, and it's a strong shell of cortical bone, and it has got core of the cancellous bone, which is also a flare of the pedicle. So whenever you are putting pedicle screws and you nibble that area, so there's a bleeding point. So that is called flare of the pedicle. If you look at the this diameter, the T4 has got narrowest pedicle diameter among all. Okay, and T12 usually has larger pedicle diameter than L1. If coming towards the lumbar vertebra, there are 5 lumbar vertebrae starting from L1 to L5. They have got massive block-like bodies, and they have got short hatchet-shaped spinous processes. Okay, and they are most solid of all vertebra. It is mentioned that even the L5 vertebra equals around 5 centimeters, so it's a good amount of bone which is available. Pars intra-articulus, it's a part of vertebra between inferior and superior articular processes. It is most developed in lumbar spine. It has got increase in cortical bone to accommodate increased forces. And if there is insufficient cortical bone, it leads to stress fractures and ultimately slippage of vertebra, that is called spondylolisthesis. The lumbar spine is lordotic, has got lordotic sagittal alignment ranging from 20 to 60 degrees, and significant flexion extension movement happens at each level. Okay, it has got biplanar facet joints. We see the proximal facet is facing in another direction, and distal facet is facing in another direction. The L2 to L5 region harbors cauda equina basically, and if you look at the vertebral body height, so the ventral height is more than the dorsal height, so that also leads to development of the lordotic curvature of the spine. The vertebra, basically, if you look at all over the vertebra, all regions, they adhere to the common basic structural design. So the basic structural design is same, but they show regional variation in size and configuration that reflects the functional demands of that particular region. So cervical spine is basically designed for increased movements. The thoracic spine is restricted to have small degrees of movement, and the lumbar spine is again a mobile unit. So the orientation of facets and structures is supposed to be like that. If you look at the width and depth of the vertebra, the width of the vertebra increases from cervical spine to the lumbar spine. So is the depth, basically. So this is the width and this is the depth. Okay. And this is the curvature we were following. If you look at the ventral and dorsal height, so if you follow this curve, the ventral height increases in lumbar spine, okay, and dorsal height decreases. So that is consistent with the lumbar lordosis. If the ventral height is more, so there is anteriorly the more curvature leading to lumbar lordosis. Coming towards the sacrum and coccyx, the sacrum is formed by fusion of 5 vertebrae. Superiorly, it articulates with L5, and inferiorly, it connects with the coccyx. The sacral promontory is the anterior and upper margin of first sacral vertebra. The wing-like ala on both the sides, they articulate with the hip bone, forming the sacroiliac joints. The posteriorly, the sacrum forms the posterior wall of the pelvic cavity. Its dorsal midline surface is roughened by medial crest, which is visible here. Okay. that is basically fused spinous processes in the sacrum. This is flanked laterally by dorsal sacral foramen on both the sides. The vertebral canal continues inside the sacrum as sacral canal, and it holds the chorda equina. So there is no spinal cord there. The canal open inferiorly in what is called sacral hiatus, that is this opening, and that is a site for caudal epidural also. The coccyx is formed from few of 4 tiny irregularly shaped vertebra. If you look at the joints between two vertebral bodies, so basically the intervertebral joint is it's a secondary cartilaginous joint. The upper and lower surface of the bodies of two adjacent vertebrae are covered by thin plate of hyaline cartilage on both the sides, and the sandwich between plates of hyaline cartilage is intervertebral disc, which is formed of fibrocartilage, and they are 23 in number. If you look at the intervertebral disc, they form about 1/4 of the whole length of the vertebral column. If you look at the details of the disc anatomy, they are basically thickest in cervical and lumbar region, where the movements of vertebral column are greatest. Okay, and if you look at the disc anatomy, it has got peripheral part, which is annulus fibrosus, and the central part, which is called nucleus pulposus, which is a mass of gelatinous material, which is made up of water, collagen, and chondrocytes. There are no disc spaces found between C1 and C2 or in sacrum or coccyx. If you look at the annulus fibrosus, it is made up of mainly type 1 collagen. It has got high collagen to low protoglycan ratio. The fibers at the periphery are oriented 60 degrees to the vertical axis of the spine and parallel within each lamina and perpendicular between edges. They are basically designed to withstand the different forces during the loading mechanism. The annulus fibrosus functions to contain the nucleus pulposus in the center, okay, and maintains its pressurization under compressive load. So whenever there is pressure, loading of the spine, the annular fibrosus restricts the movement of nucleus pulposus in the periphery. The functions of a disc include spinal movement and providing stability. It links adjacent vertebral bodies together, and it is responsible for the spinal column height. If you look at the blood supply and nutrition of intervertebral disc, it is achieved primarily by diffusion from the adjacent vertebral end plates, because per se the discs are avascular. Okay, the annulus is penetrated by capillaries for only a few millimeters, and the normal disc tissue has high rate of metabolic turnover. If you look at the nerve anatomy, the disc itself has no direct innervation. But the sensory fibers are abundant. However, in adjacent longitudinal ligaments and ALL and PLL. If you look at the joints between vertebral arches, so they are called zygapophyseal joints or facet joints. They've got different orientation in different regions, so cervical, thoracic, and lumbar vertebra. Okay, they are basically plain synovial joints. In cervical spine, they are loose and thin to provide wide range of movement. Again, if they've got wide range of movement, and because the orientation of facet sets in that position, so there are chances of jump facet in cervical spine. Okay, there are accessory ligaments which unite lamina, transverse processes, and spinous processes, and they help stabilize the joint. If you look at the articular facets in the spine, they are covered with the hyaline cartilage, and the joints are surrounded by fibrous capsule. Articular capsules per se are made of non-innervated articular cartilage, so there is no innervation of the articular cartilage, but the capsule and synovial membrane which are surrounding the joint, they are innervated with pen receptors. Okay. The specific about cervical spine is that the lateral margin of upper surface of typical cervical vertebra, they are elevated like crests or lips, forming a so-called uncovertebral joint or joints of Luschka. Okay, they found uncovertebral joints with the body above. The importance of this joint is that it indicates the early signs of decompensation at that level, and this is also the limit of decompression while you are doing ACDF, anterocervical discectomy and fusion, because just posterior to it lies the vertebral artery. If you go beyond that uncovertebral joint, there are chances of rupture of injury to the vertebral artery. If you look at the ligaments, there are mainly two big ligaments, that are anterior and posterior longitudinal ligament. They run as continuous bands along the anterior and posterior surface of the vertebral bodies. They basically hold the vertebra firmly together, but at the same time permit a small amount of movement to take place. So this is ALL and this is PLL, which continues posteriorly as a tectorial membrane. Another ligament is ligamentum flavum, which is between the lamina of adjacent vertebra. So that is not continuous ligament basically. So it connects lamina with another lamina. It's a thin, broad, and elastic tissue It is said that up to 80% it has got a stretching power. So up to 80% load it can stretch because of high amount of elastin. It resists the separation of lamina and flexion, and it assists in extension back to the normal. Another ligament is supraspinous ligament and ligamentum nuchae. It runs along the tips of the spinous process starting from C7 to sacrum, and from C7 above there is ligamentum nuchae. It resists the flexion of the neck basically. If you look at another ligament, that is interspinous ligament, which is between the spinous processes, it is thin and almost membranous ligament. It connects adjacent vertebral spinous processes. It's poorly developed in neck, elongated and narrow in the thoracic region, and thicker and broader in the lumbar region. So in lumbar area, the interspinous is thicker, and cervical and thoracic, it's a narrow structure. It blends with supraspinous ligament posteriorly and ligamentum flavum anteriorly. This is another tabulated form. It is said that the ligamentum flavum is the strongest ligament just because of the high amount of elastin in it. ALL and PLL, they are considered primary spine stabilizers. If you look at the failure strength of a spinal ligament, so this is for cervical spine, this is for thoracic spine, and this is for lumbar spine. So in cervical spine, the facet capsule basically is the strongest capsule, strongest ligament. So while doing decompression or any procedure on the cervical spine, do not disturb the facets of superior level, because they provide significant stability. In thoracic spine, it is basically the ALL which has got highest failure strength, and again in lumbar area it's the ALL followed by PLL. Okay. If you look at the muscles of the vertebral column, there are flexors which are present anteriorly. There are rectus abdominis, internal and external oblique muscles, and transverse abdominis and fast muscles. And there are extensors which are present posteriorly. They include erector spinae, multifidus, and intertransverse area. The basic movement of basic function of these muscles is that there's rotation and lateral bending. Okay, so when there's right and left flexor and extensor muscle contract asymmetrically, there's lateral bending or twisting of the spine. This is again pectoral presentation. There are superficial layer of muscles which include spinalis, longissimus, and iliocostalis, and the left sided muscles include rotators and multifidus muscle. There are deep layers. If you look at the blood supply of the lumbar spine, the lumbar vertebral bodies are mainly supplied by the segmental arteries. So the anterior area of the vertebral body is the most vascular area. Okay, and they've got dorsal branches which supply blood to the dura and posterior ligaments. Again, another clear presentation. So from the aorta, there's segmental arteries which go posteriorly, and they again give branches to the different posterior ligaments and the dura. If you look at the spinal cord blood supply, it has got anterior spinal artery and the posterior spinal artery, and the blood supply of anterior portion of cord is much more vulnerable than that of posterior portion, and can be decompensated by occlusion of large radicular branch or lesions of the aorta. Okay, so it is said that 75% of blood supply to the spinal cord is right from anterior spinal artery. Okay, so that is the main artery. Another artery, which is artery of Adam basically it's the largest of anterior radicular arteries. It's a major source of blood supply to the lower thoracic and upper lumbar spinal cord levels. If you look at the venous drainage of the vertebral column, so it has got external vertebral venous plexus and the internal venous vertebral venous plexus, which is called epidural vessels. Okay, and they ultimately drain into azygous and hemiazygous veins, and these plexuses are valveless. And as you know, the azygous and hemiazygous also drain blood from GI, liver, and other things. So that is the basis of development of vertebral metastasis, okay, in the spine, because they are communicating. In the next lecture, we will be discussing different spinal nerves. So there are 31 pair of spinal nerves. The first pair exits vertebral column between skull and atlas, and the last 4 pairs exit via sacral foramen, and others exit through the intervertebral foramina. So in total, there are 8 pairs of cervical nerves, 12 pairs of thoracic, 5 pairs of lumbar, and 5 pairs of sacral nerves, and there is 1 pair of coccygeal nerves basically. So if you look at the orientation of facets in lumbar spine, okay, so they are biplanar. Okay, so the superior articular facets and inferior articular facets, they are not in the same direction. Just like thoracic spine, if you see the thoracic spine, the facets are like this, okay, but in lumbar spine the facets are inclined like this in sagittal plane. So this facet is facing this way and this facet is facing this way. So that is why it is called biplanar orientation of lumbar spine.
This also describes why there's a jump facet in the cervical spine and not in the lumbar spine. So you need to know the anatomy very well to go for operative.
See the cervical spine vertebra from above, this one. So there are lifts on both the sides. Okay. So it articulates with the superior vertebral body and they form a sort of plain diarthrodial sort of joint. Okay. So that is called joints of Luschka. Some say it's the start of decompensation in the process of degenerative disc disease. So if there is degenerative disc disease, there is elevation of both the ridges on both the sides. Okay, so you have to decompress that area basically to decompress that spinal nerve. The another thing is that is the limit of your decompression while going posterior in the SCDF.